Thank you to the speakers. That was really phenomenal. I think a great way to end some of these sections is we just had a lot of great talks, a lot of information. A good way is application with a case. So the moderators, please, I'm going to share a case here with you guys that you guys might be, hopefully you guys can comment on. And also everyone from the audience, I want to open you guys up for commenting on the case presentation. These are my disclosures. So we have an 88-year-old male, has an infrarenal aortic dissection that extends into bilateral iliac arteries. That was first seen several years ago, over a decade ago. That was sent to us for a referral. Was asymptomatic at the time, followed with serial CT angios, and then returns a couple of years later with worsening 2 to 3 block claudication. You can see the past medical history here on aspirin and Plavix, has never smoked. And here's a CAT scan. So as we're coming down, you start to see at the infrarenal portion of the aorta, history, like you could see the little bit of old dissection that's in this area. As it starts to come down, you see that dissection really take up a lot of that aortic space. It's an aneurysm, but it's small, just to Dr. Malik's points just now. And then you see the lumen almost obliterate before you get a complex dissection that goes down to the area. And you have some iliac disease at the origin here, you can see, as well going down to the left common iliac artery. So just some initial thoughts. I don't know, Dr. Rao?
Yeah, I think this is definitely very complicated. I think part of it, the decision making, is, the three things that I always think about: conservative versus endo versus open. So he's 88, so seeing if he's a functional 88-year-old, seeing if he'd be a candidate for open. But if you're going to do something endo, and if it's within his if it would help his quality of life, yeah, I think you have to address the AAA in addition to the stenosis. So, I would probably you probably need a bifurcated stent graft, and then I didn't see how far it went down on the left side, if you could seal above the hypogastric.
So you're thinking an EVAR device?
Yeah, that would be my probably approach to this.
What do you think, Dr. Malik, Dr. Price? What?
I don't know, Dan. 88 years old with claudication. It's and how big's that aneurysm?
Aneurysm is small. The aneurysm is about like 2.5, 3 centimeters in size.
You're not going to do an open repair on this. It doesn't make sense. So some sort of endovascular repair. Again, I don't think you're really going to get you're not here to fix the aneurysm. You're just here to fix this claudication. So any of the endovascular techniques, even just kissing stents may be enough, and just line them up to the aorta and just be done. What happens at the renals?
It's pretty normal as you get up to the renals. You can see the dissection that's here, but you can see that's the renal area. Looks pretty good.
Yeah, so one of the unibody devices may be an option for something like this if you're interested, or just kissing stents up to. I would keep it easy, simple.
Yeah,
I think it's 88 and it's claudication and the aneurysm's small. You really don't want to make this worse.
Dr. Price?
Yeah, I don't think I could have said it better. He's 88, he's claudication. We have to talk realistically to him about the complications of an intervention like this, see how exactly life-limiting this is, and if it's really affecting the quality of his life. I do think potentially either an EVAR with extension into the external and potential need for embolization of that hypo on that one side, or potentially kissing iliac stents, or one stent and then fem-fem. So all of those are potential options, but I'd keep it as simple as possible.
Yeah, I think we went through this. Thank you very much for your inputs. Continued observation for a claudicant is always on the table, but if it's very life-limiting, we opted to repair this patient. Open surgical repair, I think I agree. If we're talking aortobifem, axe bifem, something like this is probably not what we're going to offer this patient who's 88. That's just claudicating. Hybrid repair, we talk about doing a fem-fem bypass, so you can take a stent graft down to one iliac limb and then do a fem-fem, or some sort of endovascular repair with bare metal stenting, bifurcated stent grafting, or kissing iliac stents. So whenever I'm presenting a case, thank goodness the panel kind of agreed with what I was thinking. So it's the same exact thing. Whenever you see a patient, you want to try to fix the problem that's giving them the issue, which for this patient was claudication and aortic stenosis as well as iliac stenosis. I agree, there's a dissection and an aneurysm there. My thought process was I don't really need to fix that. But even if I'm thinking about fixing that, I thought a unibody device that went all the way up, especially when the distal aorta is very narrow, would help. Dr. Rao touched on this very briefly during his presentation. Endologix AFX is a unibody device that was initially designed for EVAR, but it's being used for occlusive disease as well because of its structure of being unibody that can sit at the aortic bifurcation, like you can see in the picture, which is different from all the other EVAR devices that are on the market. It comes in diameters of 22, 25, 28, which sounds big, but it's also important to note that this is the only device that has the stent on the inside. So you won't really have fabric clumping on the inside of that stent graft. So the decision here was to do a AFX device. So we have a access from the left side with the main body device delivery system going up. You can see the near aortic occlusion with occlusion almost occlusive across the sheath. We still ran IVUS because the IVUS was, there was a dissection here. We wanted to make sure we were in the correct plane. You can see here, it narrows down pretty substantially at that aorta that you saw on the CAT scan, which is consistent with the CAT scan, and just had to make sure that we're in the true lumen going all the way down. The EVAR AFX device works by snaring the wire so that you can bring it and seat it down onto the aortic bifurcation. So this is the contralateral side that you have coming here. You would deploy open the limb and then be able to pull that all the way down so that it sits on the aortic bifurcation. There's always a little bit of concern that you can snowplow some thrombus while you're doing this, but we did this very carefully. And after the deployment, this is what you can see. Dr. Rao mentioned this as well in his talk about complications. We had some dissection that was continuing to go down onto that right side. Here's the left side. We were able to land shy of the hypo. And on the right side, we just extended. We ballooned the entire limbs, and we had to extend a stent graft to the right side for extension. So once again, it's a pretty straightforward case in terms of a aortoiliac occlusive, and this is where something like an aorto-uni device I think is really powerful. We will show you the CAT scan and follow up. So you can see we ignored all of this because we weren't necessarily here to treat the smaller aneurysm. Here's the start of the aorto-uni graft. We're able to get a pretty good diameter that's coming through this segment with good patency and resolution of symptoms. You could see some areas of residual disease here in the the left common iliac, as well as above the aortic stent graft. I don't know, would anyone go after that and treat it? No, I think. What are your thoughts about putting in a kissing iliac stent in a case like this with like a pretty narrow distal aorta?
I think it's reasonable too. I mean, you went the AFX route, and the data is good for using them for aortoiliac occlusive disease. NYU has published a fair amount of, I think they probably have the largest database about doing this. There's a little bit of risk of embolization from these cases, but in general, they do well. But I think kissing iliac stents is, covered iliac stents or something is probably reasonable too. He's 88, you have to see how long he's going to be around. Again, make it easy. It shouldn't be a complicated case.
Yeah, I think I agree with that. I think kissing stents would have worked here as well. I mean, if he was in his 60s and he had that AAA, then I would think twice about that because you probably want to address the AAA as well. But like everyone's saying, he's 88, so I think this will be a durable repair for him.
Do you went up the right side, Dan?
We went up the left side because that's the side that had the dissection, and we wanted to make sure we were true lumen through that dissection when we were sending up the delivery system.
I guess my other question is, would you consider a CRAB in this case?
Yeah, I think that was the other option. I think CRAB with using any kind of balloon expandable stents, I was a little worried about before I ended up putting a cover stent in place because you're always worried about toothpasting kind of thrombus or things from the location that it's currently in. You still have hypogastrics that are open and lumbars that are open.
Yeah, that's exactly what I was going to say. I mean, this patient is a dissection patient. It's not purely an aortoiliac occlusive disease from atherosclerotic disease. So you always have to think about radial force, and particularly in the setting of a dissection.